This is One on One. We're pleased to welcome Dr. Marianne Holler, Chief Medical Officer of Hospice Palliative Medicine and the Advanced Care Institute at VNA Health Group. Good to see you, Doctor.
Thank you. Nice to see you.
That's a loaded title. Clarify that for us. Break it down.
Well, advanced care and people with advanced illness experience a spectrum of touch points with the healthcare system. So a lot of times their first contact is obviously with their primary care physician, a specialist. They end up in the hospital. And as illness has its natural trajectory, exacerbations, declines, they need different types of services along the way. So palliative is for anybody at any point in advanced illness.
What's hospice then?
And then hospice is palliative care at the end of life. So somebody has reached a point in their illness that they want to focus on goals that are important to them, spending time with the people that are important to them, kind of let go of that in and out of the hospital and continued decline and focus on quality and doing things they find enjoyable. So it's palliative care more towards the end of life.
Doctor, for millions of families, ours just being one of them, who has dealt, continues to deal in some cases with end-of-life issues for our loved ones, why do so many of us have such extraordinary difficulty dealing with it and making the best decisions? Because, I know it's a loaded question, I know, it's just too overwhelming.
Right. And I think there's a lot of noise around end-of-life care in terms of, competing agendas. I mean, at the end of the day, if you ask somebody, what's your goal? The goal is, I want to live as long as I can. And that's great, but that's not a goal we can achieve. Like, we can't make you live to be 150. So when illness gets advanced, people think the only way is to keep coming in and out of the hospital, in and out of intensive care.
Get me better, right?
Right.
But at a certain point, does it become counterproductive?
Yes, and it's, a lot of studies say, people on hospice end up living longer because they're focusing on symptoms, they're focusing on pain control, if they're short of breath, getting, those types of things under control so that they're living their best day every day. And the medical community, my colleagues, aren't really equipped. We are not coming out of medical school trained in what to do when life comes to a natural end. We are taught in medical school the patient has A, we're supposed to do B. And we kind of get lost in, well, what do we do when B's not working? Or we're into third, fourth line therapies and interventions, and the patient's life, the hospitalizations become closer and closer together, and their functional status and physical status continues to decline.
But Doctor, with technology, being able to do more and more, keep people alive longer, do things that heretofore were not possible before, has it, dare I say, complicated things as well?
Absolutely. And this is an indictment of the medical system.
Not at all.
There's so many great technologies that have changed the outcome for patients. The problem is pretty much since 1945, like around World War II to the 70s, we've had this explosion of technology that changed the outcome for patients. Wonderful technology that people are able to live longer and better and more productive lives.
There's a but coming.
However, when life comes to a natural end, we're not sure when that technology is a greater burden than a benefit to the patient. And we, the medical community, is not stepping back and asking, what's the goal? Is this how you want to live your life? So all that technology, we're starting to use that as end-of-life care tools. For instance, we developed feeding tubes in the late 70s, and they, were actually designed for the pediatric population. Then they started being used for adults, but to get you through a certain period of time in your illness, until you could get on your feet, till you could take in proper nutrition.
Not an extended period, not months, years, correct?
Correct. They were put in for a set period of time to improve somebody's health till they could develop.
Doctor, I'm curious about this. Dying peacefully. You told our producers that should be our goal? Shouldn't our goal, I'm devil's advocate, I want to live as long as I can. You're
do.
saying, let's try to die peacefully.
Well, when I see a patient for the first time, I ask them, what is your understanding about what's going on? Because then I get to hear what they think they're hearing from the medical community. And it's interesting because we, physicians, nurses, we want to put a positive spin.
Do we hear what we want to hear as patients?
Yeah. And I think doctors say what they're comfortable saying. Like, oh, your heart's no worse, or your kidneys are, stable, like those types of things. But putting the whole picture together and what it means to this individual and the things that they value is the complicated thing. So once I ask, what have they told you about what's going on, that gives me the opportunity then to clarify what that means in this individual.
We have a few seconds left here. Where did you get the skill set, the empathy, the compassion, the ability to do this?
Well, I had an interesting road to medical school. I was a social worker for 18 years first, but many of my colleagues in palliative care came up through internal medicine, before I went to medical school. So I had a skill set from being a social worker for so long. So that certainly aided me much more than the skills in medical school. So it was a perfect combination.
Thank you for all the families, all of our families.
Thank you.
Who are dealing with end-of-life issues, for those we care about the most. Thank you for what you and your colleagues do every day. Thank you, Doctor.
Thank you.
Stay with us. We'll be right back.